Hi, everyone. I guess the music has stopped, and that's my cue to start today's meeting. Good day, good evening, good morning to everyone. I think not only around Asia, but also around the world. Welcome to a special session from the ASPA ASPA Pediatric Pain Special Interest Group. And today we're going to talk about a lot of pain, and I think it's going to be a great topic to talk about because we are going to talk about headaches and back pains and abdominal pains. I think everyone in this room, if you're an anesthetist or an anesthesiologist, I think you've had this episode of pain like sometimes in your life, and it would be great to share the stories behind this pain. And I would like to welcome you to the session for today. I would like to introduce myself beforehand. My name is Gezi Giwang Kanchana. You can call me Gezi. My last name is a little bit complicated, I think. I am a pediatric anesthetist and I work at a referral and teaching hospital in Bandung, Indonesia. I work with the Pediatric ASPA, also especially with the St. Jude Global Alliance for Palliative Care for Pain in Children. And I have two very beautiful moderators with me today, and also some incredible speakers. And our moderator, okay, we have our speakers, a moderator again. Our moderator for today will be Dr. Ye Yun Pang. She is a consultant pediatric anesthesiologist from the Department of Anesthesia and Critical Care of Hospital Tengku Aziza in Kuala Lumpur Women's and Children's Hospital, Malaysia. Good afternoon. She's a member of the MSA, the Malaysian Society of Anesthesiologists. We've met, I think, a couple of years ago at the ASPA event in Malaysia. And she has a lot of interest, especially for pain management and regional anesthesia. And our third moderator for today will be Dr. Raylene Diaz. Hello, how are you? She's an associate professor and head of Department of Pediatric Anesthesia at the Seth GS Medical College and King Edward Memorial Hospital, Mumbai. Also the executive committee member of the Indian Association of Pediatric Anesthesiologists. She is very interested in everything USG, I think, and everything focused inside the small bodies of our patients. And we are all going to moderate you through this session. And for the next session and the house rules, I'm going to hand it over to Yayun.
Thank you very much, Dr. Gezi, and good evening, everyone. It's Yun here from Malaysia, and a warm welcome to all the colleagues joining us from across different time zones, I guess. So on behalf of ASPA Pediatric Pain SIG, we are delightful to have you with us today for Pain Without a Playbook, practical thinking for the pediatric pain problems we commonly see. So before we begin, let's have a quick housekeeping reminders. This webinar is being recorded and will be available on ASPA's platform after the session. So kindly submit all the questions through the Q&A section only. The chat and raise hand function are disabled to help us to manage the session smoothly. Our moderators will direct your questions to the appropriate speaker during the panel discussion. Some questions may also be answered in the text during the session. Each speaker will begin with a poll question, and you have 30 seconds to respond, and we will share the result immediately after the poll closes, and you may close the poll section. Certificates of attendance will be automatically generated and sent to those who complete the post-webinar survey via a link sent tomorrow. So please ensure your full name and email address are being entered correctly. We encourage active participation, so please do share your thoughts and questions throughout the session. So with that, I hand over to Dr. Raylene to start and introduce our first topic and first speaker. Okay, Dr. Raylene, it's for you.
Yeah, thanks, Dr. Yun. Welcome, everybody. It's so good to have you all here with us. And thank you so much for this honor. And it indeed is a great honor to introduce to you all Dr. Ayuko Igarashi, who's going to be our first speaker for this session. I don't think Madam needs any introduction, but for those of us who are new to ASPA, Madam is the anesthesiologist in chief at the Miyagi Children's Hospital in Sendai, Japan. She is also the clinical associate professor at the Tohoku University in Sendai, Japan. Madam is a delegate member of the Japanese Society of Anesthesiologists, and she's also the director of the Japanese Society of Pediatric Anesthesia. So, Madam is an ardent pediatric anesthetist here, and she has a special interest in chronic pain in children. She's also a part of the of the palliative care group, and Madam is so dedicated to this cause and also to the cause of pain in children that she's one of the few people who I know who actually monitors ANI intraoperatively in children to study pain. So it's so good, Madam, to have you here with us and to learn from you. I would like to now open the house to Madam. Before that, we have the poll question. So you all can answer this. You all will have 30 seconds to answer. What is the percentage of children who experience a headache within 1 year in the global pediatric population? Is it 3%? Is it 10 to 20%? Is it 30 to 40%? Or is it as high as more than 40%? Okay, so we have the answers.
Okay.
So maximum people think it's 10 to 20%, followed by 30 to 40 and more than 40 having an equal incidence here. And very few think that it is very less. So we'll see the answer as Madam moves ahead with her discussion. Over to you, Madam.
Okay. Oh, okay. Hello, thank you for the nice introduction, and thank you for having me here to discuss about the headaches in children. Because I am pediatric anesthesiologist, I have plenty of time talking with children before anesthesia. And I found that there are many children with headache. And my assumption was like maybe more than 10% of school children have headache. So let's check with the audience if my assumption was right. Oops. So to my supplies and to most of the audience supplies, it's more than what we thought. Of course, statistics varies by country, but the highest is 67% and the lowest is 19%. And in most of the countries, the prevalence of pain in children is between 40 to 50%. And not only children have experienced headache from one time to another, 42% of children with headache experience restriction of daily life because of headaches, such as low attendance at school. And 40 to 70% of children who suffer from headache will likely have headache in their future, in their adulthood. So let's go back to my country's statistics. Like many countries, almost half of the Japanese children, especially school age, experience headache. And if you look at this graph, for example, in elementary school, 3% of children suffer from migraine and 5% tension-type headache. And the number just goes up. In high school, surprisingly, 50% of children experience migraine and 26% tension-type headache. And it's more than that because up to 4% of children have chronic headache. Chronic headache are defined as having headache more than 15 days a month and for longer than 3 months. So it is such a huge disturbance to their school lives. Headaches are not just headaches, they have names, and they are classified into two categories. One is called primary headaches, and another is called secondary headaches. Primary headaches are called primary because the mechanism of pain is intrinsic to the brain system. And the most common primary headaches among children are migraine and tension-type headache. Secondary headaches are different. They are caused by systemic condition or diseases like brain tumor or intracranial bleeding, But the most common cause of secondary headache in children are viral infections like flu. And some children experience headache because they don't sleep well, they are dehydrated, or they're just tired and hungry. And some children with psychological background also claim headaches. So there are many headaches which remain undiagnosed. And if you look into this graphic, you can see that only 20% of headaches are diagnosed. And the rest, almost 80% of them, remain undiagnosed. And the right side, left side is a picture I took the other day in a drugstore in my neighborhood. It's one of those very small drugstores, but the whole shelves are occupied with a various brand of just painkillers. So you can imagine that many people or the children just drop in one of those drugstores and buy over-the-counter drug and ease their pain without proper diagnosis. And probably most of them or some of them are undertreated. So what should we do with headaches in children or in adults? The first thing we need to do is assessment. The question to be asked with patient are how frequent is your pain and how severe it is, and when do you have headaches? Is it acute or chronic? Or identification of pain triggers or pain relievers, if any, and also inquiring family history and seeking any red flags which indicate a serious condition behind the headaches is really important. And once assessment is made, diagnosis. Is it primary or secondary headache due to very minor conditions, or maybe secondary headaches which need immediate referral to a specialist? And treatment. Treatment consists of 3 steps. Pharmacological pharmacological treatment such as painkillers, ibuprofen maybe, and non-pharmacological treatment like putting a patient in a quiet and dark room or let them sleep, have adequate hydration, good diet, a bit of exercise, or sometimes psychological management like educating patients to avoid triggers or stressors work fine with some of the patients. So what should we know about the headaches which need further diagnosis or treatment? A SNOOP 10 is a list of the clinical signs which indicate the secondary headache requiring the referral to a specialist. And this table can be shared with adult patients as well as children. But some of the signs are specific in children. For example, headache under 4 years old and headache in children with increasing head size or a history of VP shunt. And nighttime or early morning headache indicate the increase of intracranial pressure or maybe obstructive sleep apnea syndrome. Occipital headache may be quite rare in children, so it may be related to brain tumor, and headache with any sign of developmental regression. In that case, children need to see a neurologist. So now we go back to the primary headaches in children. There are 2 kinds of primary headaches which are quite common in children: tension-type headache and migraine. Tension-type headache is a continuous, mild to moderate type of pain. And it can last hours or sometimes days. It's continuous. Migraine is quite different. Migraine is like a pain attack. It's very severe pain, and some patients say that it's like a stinging by the needle. And it can last hours or sometimes a day or 2. But in small children, it can be short as short as 30 minutes. And also in very small children, cyclic vomiting or colic could be the sign of migraine attack. And it's important to remember that the two primary headaches can coexist in one patient. So one day patient have tension type headache, another day they are attacked by migraine. Regardless of the diagnosis, medication is quite important. The first line of treatment is ibuprofen. As Anna said, there are some concerns about Ray's syndrome, especially if they are prescribed to children. So ibuprofen may be the best choice. And if patients have allergy or other conditions described in this slide, then acetaminophen could be the choice of drug. For migraine, you can prescribe triptans, but this drug is for older children and for patients who find the ibuprofen or acetaminophen not really effective. And in children, sometimes anti-epileptic drugs can be prescribed to ease their pain, but their efficacy is not really clear. So medication is quite useful, and medication is a key to treat the pain. But relying too much on medication invite unnecessary problem called MOH. What is MOH? MOH stands for medication overuse headache, and it occurs in patients who suffer chronic pain and who use too much painkillers. How much is too much? Well, in case of ibuprofen, for example, use the drug more than 15 days a month, or if they use triptans or opioid, more than 10 days a month. It is considered to increase the risk of MOH. And its affect almost 7% of global population, so it's not rare. Symptom is the same as the original headache, but it gets more severe and it occurs more frequently. When treatment is easy, just not to use medication so often. Of course, it's easy to set and done. So the best way is to prevent it before it's happened. Educate patients when you prescribe the drug that they need to take the medication 3 days a week or 10 days a month, not more than that. It's quite important. So relying too much medication doesn't solve the problem, especially in case of chronic pain, and sometimes invite unnecessary problems. So I'm going to present a case of 10-year-old boy with chronic headaches. His headache started after a big sports day in school. And after the event, he started saying that he was tired and he had a headache. He started to skip school. And because of that, mother took him to a clinic and he was diagnosed having migraine as well as tension type headache. And he was prescribed 4 types of medication for that, but they are no use. And he started to lose his weight and fatigued all the time. And he started to say that he had numbness in his finger as well as his feet. So he was referred to our institution. Neurological examination showed nothing, but his blood tests showed that he had very low level of protein. So colonoscopy was performed and resulted in the diagnosis of protein losing enteropathy due to Crohn's disease. Treatment for Crohn's disease started, and despite the improved colonoscopy findings, the boy's pain persisted and it got worse. And he just stick to his bed all day. He didn't move at all. So his mother demanded further examination to find the source of pain, as well as change his prescription to opioid for better pain relief. So what did we do with this patient? A call for help to our multidisciplinary palliative care team was made. And we scrambled to hold the meeting. And in the meeting, we discussed all of his problem, about his pain and about his school problem, about his home, everything. And we came up to 6 plans. Pain assessment and increase his physical and school activities and introduce some psychological evaluation and discussion with mother about his family and school problems and medication. And this is the detail of our plans. For better pain assessment, we introduced a pain diary, which I will show you later. And to increase his school activity and to fill the academic gap because of his long school absence, we enroll him in hospital school and enable him to attend the classes in his wheelchair. Also, for psychological evaluation, clinical psychologists start involving, and child life specialists also start engagement with the boy as well as his mother. And previously, he was really reluctant to do any physical rehabilitation. So the therapist introduced Nintendo Wii Fit program for his program to make the program more fun to this boy. And also, we encourage mother to take him out for eating out or shopping, or weekend stay at home, so she can understand his situation as well as what she could do for him. And medication, we didn't change the medication, but we thought about timings and dose and schedule. And we instructed more better timing of medication and dose to mother as well as boy. Also, to meet mother's demand to add some pain medication, we introduced Japanese herbal medicine called Kampo. This is a pain diary we introduced to this boy. And you can download this content from the pharmaceutical company site, but sadly it's in Japanese. So you can do the same thing with just a notebook. And what patient need to fill in is the date and the pain scales and the timing of medication, sleep condition, school condition, appetite, and mood of the day. And by writing this diary every day, a patient can understand their pain patterns and probably the triggers and relievers as well. And also, it can improve the communication between the patient and the medical professionals. And also, we expect that the patient can regain their sense of autonomy of their pain treatment by writing this book. Alternative treatment is proven quite effective to treat lots of chronic pains, and headaches are no exceptions. Alternative treatment for headaches included acupuncture, Botox feedback, and the herbal medicine like Kampo, yoga, or Botox injection. For children who are afraid of pain or needles, Kampo is really a good and convenient alternative. It doesn't necessitate any pain to children. I have to give our audience a small lecture about Kampo medication. Kampo is a traditional medicine using combination herbs. It was introduced from China around 7th century and revived until 17th century when most of the formulas we use today were established. And Kampo medication is totally integrated into the Japanese national healthcare system now, and many doctors prescribe Kampo in various clinical settings. One example is that we use Kampo to treat withdrawal syndrome in babies and neonates in ICU. Kampo medication are expected to ease symptoms such as fever, pain, digestive problem, or sometimes mental disorder like depression and irritability in babies. So what happened with this boy? The boy started to participate in school At first, he only attended an afternoon class because he couldn't wake up in the morning and also in wheelchair. But after he started to regain his physical ability to walk, maybe because of Nintendo program, he was able to join the class fully and ditched his wheelchair. And having classmate and school activity kept him busy, so he had less screen time, which is of course very good for his headache. Mother also found out that he was the only kid who couldn't ride a bicycle in his neighborhood, so helped him to practice bike at home. So he wanted to go home more and longer. With more regular schedule of medication, his pain, especially abdominal pain and headache, subsided, and headache became less frequent. And at the last, he was discharged back home. Compo medication seemed a very good fit to him, so he kept taking the medication even after he was discharged back home. So at the last of the lecture, I want to tell you just one interesting phenomenon. It is called brain gut axis. Like this case, abdominal pain and headache are the two most common pain in children, and sometimes they coexist, and making the situation more challenging for physicians. Why is that? It is said that there is a link connecting the brain and gut health, and it is called brain-gut axis. Once the mucosal barrier of the intestinal field was disrupted by inflammation or intestinal disease, like this case, microbiota or immune system in the gut is activated and sends a signal to the brain. And the brain just emphasizes the sensitivity of pain. So if you have a children who have both headache and abdominal pain, please keep this phenomenon in mind and treat not only one pain, but treat the well-being of the patient. Not only pain, but the whole well-being of the patient matters the most to the pain treatment. So to conclude my presentation, this is my last message. Headaches are a global epidemic affecting lots of young people. And headaches in children impairs their quality of life, lead to headaches in adulthood, and will become a significant burden to the society. And chronic headache treatment are not all about medication. It sometimes requires multidisciplinary team approach that invent creative approaches to children. That's all. Thank you.
Thank you so much for Dr. Ayuko for a very, very interesting topic on headache, and I'm very sure that there's going to be a lot of questions after this, but we will move on to the next session, which is from Dr. Richard Kim. Hello, all the way from the US, and his presentation is going to be about an unusual presentation of back pain. Dr. Kim is the clinical associate professor from the Division of Regional Anesthesia from the Department of Anesthesiology, Perioperative and Pain Medicine from Stanford University School of Medicine in Stanford, California, United States. And I think I just found out that his biggest hobby is actually about electronic medical systems. And we are waiting for you to create an easier and cheaper alternative, maybe a global one, coming from Silicon Valley. I think you're closer to them than to us right now, but now we're going to discuss more about back pain. Dr. Kim, the floor is yours.
Thank you.
Before,
I'll,
should I introduce your question first?
yeah,
You
I'll pause a
wanted.
bit for the poll question. Yeah.
Yeah, so just a couple of seconds. We'll ask the audience, what do you think about continuous peripheral nerve blocks? Do you think they delay physical therapy or do they delay hospital discharge? It could be true and false. And I think you can answer here at the poll. But I think a lot of countries in Asia have not yet embraced continuous peripheral nerve blocks in the hospital. So it will be something quite amazing for them. I think a lot of audience to hear that you actually have children bring the blocks home. Yeah. Dr. Kim, the floor is yours.
Someone else is sharing. And try that one more time. All right. Can everybody see my slides?
Yes, we can.
Perfect. Well, again, thank you very much to the Asian Society of Pediatric Anesthesiologists and this special interest group for inviting me to talk a little bit about back pain. Although this might be an unusual detour for everybody here. So let's just jump right in then to the case. So I hope everybody's familiar with, to some degree, with American cheerleading, especially if you've seen something like Bring It On. But 15-year-old, 50 kilogram, 155 centimeter young lady presents to her school clinic nurse with new onset lower back pain. She landed funny during some cheerleading rehearsal a few days ago. Feels worse after walking between classes, especially with a heavy backpack. Her right groin seems to ache a bit as well, but she's in the middle of her period. She doesn't really know if this is like related to her period or to just this landed funny business. She's otherwise healthy. She doesn't have any other injuries. She's got great grades at school, has never missed school. She feels safe everywhere. She doesn't take any meds. The clinic nurse takes her vitals. Everything's normal. There's no rash over the back, no focal tenderness to palpation. Back looks normal. She seems to walk normal as well. And she asks the patient to extend forward and flex backward, and no issues. So, as anesthesiologists, we are trained so well to just get the red flags all out of the way. So let's just knock these out first. Progressive neurologic deficits, if there's any sort of sensory losses, if there's a loss in the rectal tone or loss in bladder control, any unusual night pains, pain that basically wakes the patient up in the middle of the night, any fevers, any acute swelling in the back. These are all signs that this nurse, as well as you, should you ever see a patient with back pain, you need to escalate the patient to urgent or some higher level of care, because you're worried about infection, you're worried about cancer, you're worried about something happening that's obstructing the normal flow and physiology of the spinal cord. So then how does pediatric pain differ from that of adults? The prevalence, unfortunately, is remarkably high. And as children get older and transition to adolescence, the prevalence continues to increase. Yet, out of all these cases, care is sought in less than 1/3 of them. And out of all these cases, 10 to 15% go on to develop chronic back pain. Just comparing the most common causes of back pain, lumbar muscular strain seems to be shared across age groups, but you can see that the differences begin to really come out after muscle. And as you can possibly imagine, postural back pain and muscle imbalance seems to be much more prominent in childhood rather than in adulthood, because as the spine ages, adults unfortunately have to deal with the possibility that different components of the spine could be herniating, that the bones are literally getting older and causing degenerative joint disease. So the initial assessment management, the school clinic nurse suggests that the patient has sports-induced lumbar strain, which is fairly reasonable at this point. She recommends rest from cheerleading, icing the lower back as needed, taking ibuprofen as needed, and recommends that the patient follow up with their pediatrician if her back pain worsens. She suggests that the patient use a rolling backpack. And by rolling backpack, I mean, if you've ever basically gone to the airport, a piece of luggage to just wheel around all of her textbooks and her notebooks, which I would think in the middle of high school is basically social suicide. So I don't think this particular patient chose that. But what is the evidence on heavy backpacks and lower back pain? The most comprehensive meta-analysis and systematic review that looked at this actually found that there, across all these studies that were ultimately included in this particular review, that there was no linkage that could be found to provide some sort of causative reality to this. So the level of evidence basically suggests that backpack weight can cause pediatric lower back pain is low. And current best evidence suggests that it is not a primary driver of low back pain, but it can contribute to just transient discomfort and posture changes. So then 3 months later, the patient says, goes back to the pediatrician with worsening back pain. The patient says that she had to continue with her cheerleading rehearsals for competition, and so her back pain has worsened. Surprise. So the right groin pain has not improved after her periods, and it seems to exacerbate now with her back pain. The pain worsens throughout the day, making her want to rest earlier. She's tried ibuprofen, she's tried paracetamol. They've been moderately helpful. So her physical exam shows that there seems to be a trendelenburg gait with slight right-sided weakness. And when the Faber and Thadier tests are conducted, the acronyms here are shown below, and the maneuvers that are shown that these tests require are shown here as well. It's positive for deep groin pain, and she's really apprehensive when you're trying to externally or internally rotate her hip. And she can't stand on her right leg for longer than 10 seconds because of the pain. And this time around, when she extends her back, that back pain is reproducible. So what is this? Perhaps you're already running through your differential and you're thinking about, where these pain sources are focalizing. So a pelvic X-ray is conducted. So the left X-ray shows 2 normal hips, but the one on the right shows a dysplastic hip with where the red arrow is shown. The hip socket is shallow, and there is only partial coverage of the femoral head. So just to take a step back with hip anatomy, the hip is just one of the body's largest joints. It's a ball and socket joint. The socket is formed by the acetabulum, which is part of the large pelvic bone, and the ball is the femoral head, which is the upper end of the femur. So the acetabulum is ringed by really strong fiber cartilage called the labrum, and the labrum forms a gasket around the socket, and it creates a tight seal and helps hold the femoral head in place. And when this ball and socket joint is unable to maintain its own lubrication and continues to grind bone on bone, we begin to see a phenomenon called acetabular dysplasia. Some risk factors for acetabular dysplasia include developmental dysplasia of the hip, a history of infection at the joint, history of trauma at the joint. And the presentation is highly variable. Usually, patients will say, will present with groin pain directly, and usually it's associated with activity. But at least in my experience, patients will rarely say that their pain is localized to just one area. It's just kind of broad, and it just seems to be vaguely in the general hip area, and you try to tell them to point with one finger where it is, and they say, well, it's somewhere around here. So you start there, and you try to work your way towards the definitive source, definitive cause. In developed countries, DDH is most commonly linked to breech presentation, some sort of family history, female sex, and it's often detected early through screening. Yet in this patient, we don't know of any history of developmental dysplasia of the hip. So almost 50% develop early onset hip arthritis if it's untreated. It takes almost 5 years to diagnose on average, and usually patients have to go through 3 different clinicians just to figure out that they have some sort of acetabular dysplasia. So how does acetabular dysplasia exactly work? The pathophysiology is really comes down to the formula pressure equals force over area. As the area of the acetabulum declines, pressure rises, and pressure especially on the rim of the acetabulum, called edge loading, will erode the cartilage. The cartilage, like nerve tissue, has little potential to heal or recover. As cartilage is lost, arthritis increases, and then pain, and then stiffness, and then inability to walk. So the pediatrician recommends referral to a surgeon, but the patient and her mother elect to defer surgical consultation at this time, preferring instead to withdraw from cheerleading altogether, do some physical therapy, and take some NSAIDs as needed. So as you can see on the right side here, we're basically following through what most people would consider as the appropriate algorithm for back pain, really. We've gone through a thorough history and physical exam. We've started with some conservative therapy. We've considered some imaging. There's a suspicion of a diagnosis. At this point, the patient chooses to elect conservative therapy, and that's totally fine. But what is the rate of a hip being replaced in patients with hip dysplasia? So out of this group out of Mayo Clinic looked at hundreds of patients and ranked their patients according to a type of classification called the tonus classification. So they on the left-hand figure here, they're looking at how from the lowest tonus grade to the highest tonus grade, how many people are free from having to have a hip replacement. And you can see that the higher the tonus grade, the earlier essentially the patients will have to get a hip replacement because they're already at end stage hip disease. And on the right-hand figure, you're seeing essentially, again, the same kind, a different kind of reflection of this phenomenon, that as tonus grade increases, that the incidence of hip arthroplasty increases dramatically at 5 years and at 10 years, whereas those that undergo an early diagnosis and early intervention, and I'll get into what PAO is in a moment, early surgical intervention, the survivorship of and the risk of transitioning to a hip replacement dramatically decreases. So the lesson here is that not all patients with hip dysplasia will have to have their hips replaced. Depends on how early it's detected. So 3 years later, patient's now 18 years old. She presents with right back and hip pain. The pain level now varies in severity, but it's typically worse during sitting. Prolonged walking or hiking causes occasional popping noises in her hip. The pain feels achy, it's deep. She's seen a physical therapist, a chiropractor. She's avoided cheerleading altogether. She's been taking ibuprofen. Now it's not really covering much pain at all. So in addition to the pelvic x-rays, now the MRI shows a partial labral tear. And the femoral head otherwise looks like a normal sphere. It's not aspheric or it doesn't have any weird contours. The acetabular cartilage is otherwise looking pretty healthy, and there aren't any cysts along the acetabulum. Now, I point out all of these in the MRI because quite a few of these are criteria for the surgical team to figure out if this patient actually qualifies for something called the periacetabular osteotomy to address both the hip dysplasia and the labral tear. So what is a periacetabular osteotomy? So a PAO corrects the acetabular dysplasia by cutting into the acetabulum from the pelvic bone and then repositioning it so that the femoral head will be supported and fit deeper into the hip socket. And the procedure essentially aims to improve function for the patient, alleviate pain, and delay hip osteoarthritis. And most importantly, PAO preserves the natural hip joint, postponing or completely negating the need for a total hip replacement. So how do we manage this perioperatively? Perioperatively, preemptive opioid-sparing multimodal analgesia is usually the key words that we'll discuss and implement in order to maximize the patient's enhanced recovery. And some of these elements include paracetamol, NSAIDs, and non-opioid medications such as ketamine. There is neuraxial anesthesia and analgesia. And then there are peripheral nerve blocks, which can be implemented for both anesthesia and analgesia. What are some of these peripheral nerve blocks? Quite a few options, really, depending on how the surgeon chooses to approach the hip and where the incisions rest. The lumbar plexus block, the fascia iliaca, and femoral blocks both are addressing the nerves that are directly innervating the pelvic bone, the acetabulum, the femoral head, namely branches essentially of the lumbar plexus. I point those two out especially because I've had a former fellow of mine describe the lumbar plexus as the endoscopy of the femoral nerve and the fascia iliaca as the colonoscopy of the femoral nerve. You're just coming at it from two different, one from one side and one from the other. But one can be a bit more complicated than the other. The fascia iliaca can tend to be a little bit easier and more approachable for those that are enthusiastic but not quite as advanced in their skills with regional anesthesia. There's the PENG block, which directly deposits local anesthetic on top of the pelvic rim. And then the TAP block, surprisingly, what that does is it relaxes the muscles around the pelvic bone itself and can help reduce any incisional discomfort, as well as just relax the muscles in this immediate area so that post-operatively there are lower risks of spasms in this area. So at Stanford, what we routinely do for periacetabular osteotomies, we have one surgeon who routinely performs them in the pediatric transitioning to adult population. And we routinely perform lumbar plexus catheters for these patients preoperatively. And then intraoperatively, the patients are able to enjoy a general anesthetic, albeit with far much less opioids than even the intraoperative anesthesiologists are expecting. And then postoperatively engage in physical therapy starting on postoperative day 0. So do continuous peripheral nerve blocks delay physical rehabilitation and discharge? I hope everybody saw yes, but the answer is no. There are many studies that have already documented this, especially in the adult population. And unfortunately, while we still have to build that evidence in the pediatric population, it at least publish it and document it. We continue to see evidence that ambulatory catheters allow patients to participate in PT or occupational therapy over longer distances with greater ranges of motion and essentially earlier, and that the patients are on average are able to discharge an entire day earlier. So the patient undergoes PAO under a general anesthetic with a lumbar plexus catheter. 3 months later, the patient reports having some mild lower back and lateral hip pain, but has been hesitant to resume activities she once enjoyed, such as running and hiking. So Dr. Igarashi already had mentioned this key component, but can't miss the psychological component to any of this. 1 in 3 youth with chronic pain will meet criteria for some sort of anxiety disorder. 1 in 8 will develop criteria for depressive disorder. And the avoidance of normal behavior due to some sort of fear needs and the catastrophizing then of the pain because of the fear cannot be understated, because it continues to ramp up and heighten, will ultimately go on to have some sort of mental health diagnosis. And it needs to be broken somehow. Perhaps broken is the wrong word, and the more appropriate language is it needs to be talked out in some way. And the best person to perhaps do that, and the person most equipped to provide that, is perhaps the pain psychologist. So at Stanford, through the Pediatric Pain Service, in the outpatient setting, we have pain psychologists who are able to meet with our patients in the postoperative arena, and go through cognitive behavioral therapy, as well as different kinds of talking sessions, allow them to engage in group sessions so that they can commiserate, but also learn from their peers on how they've navigated surgery and recovery as well. So repeat MRI showed no new pathology in this patient's symptoms. Pain specialist referral led to involvement of now a pain psychologist, more physical therapy, and other non-pharmacological analgesic options, such as TENS therapy. So the key points here, this has been pointed out earlier as well, and I suspect this will be a common theme, but one should never assume that a child presenting, or even a teenager presenting with back pain is due to some desire to avoid school, some sort of mental health issues, some sort of malingering behavior, because kids and adolescents will rarely find their way, like put their foot inside a clinic's past the clinic's doorsteps just because they have back pain. They usually have a real reason to actually present to a clinician. So never assume that. The second point is that early diagnosis of acetabular dysplasia can maximize probability of hip preservation. And continuous regional anesthesia and analgesia can shorten time to physical therapy and the time to discharge after major orthopedic surgery. And on the right here, I show now the comprehensive algorithm for how one can approach back pain. With that, thank everybody for their time, and I will stop sharing.
Thank you very much, Dr. Kim, for your very insightful presentation. I do see referral for back pain. I will keep in mind that acetabular dysplasia could be one of the reasons. Okay, thank you very much again, Dr. Kim. And it's now for me my great pleasure to introduce our final speaker today. And we are very honored to have Dr. Lakshmi Vas to have with us. And she is the director of Ayuko Institute of Pain Management and Research in Mumbai, India, and honorary consultant in pain medicine at KEM Hospital and State Medical College. She has extensive experience in pediatric pain, neuropathic pain, complex regional pain syndrome, and in musculoskeletal and neuromyopathic pain mechanism, including ultrasound-guided intervention. So today, she will share with us a novel understanding of abdominal pain and its treatment. Before we begin, let's start with her poll question. Can muscle be primary pain generators in visceral pain? Yes or no? So please take a moment to cast your vote and we will see the results. All right. All right, here we are. Okay, majority of us mentioned that muscle can be primary pain generators in visceral pain. So what's the correct answer? Let us invite Dr. Lakshmi to explain in her talk later. Dr. Lakshmi, the floor is yours.
Good afternoon, everybody. And Teddy, thank you so much for inviting me to share my novel understanding of abdominopelvic pain and its treatments with my favorite set of doctors, pediatric anesthesiologists, and giving me an opportunity to return to ASPA after almost 20 years. So in 2002, I was a freshly minted pain specialist after 20 years of pediatric anesthesia, enjoying the challenges of difficult peds, airway, and regional anesthesia in a big way in those years. And then I decided to do the bungee from the heights of pediatric anesthesia to the bottom rung of chronic pain where I knew nothing. And believe you me, this physical bungee was far easier than the professional one that I did. So when I came into pain management, I went by the book. I would do blocks with C-arm guidance, ultrasound guidance, everything absolutely to the T. I would find good relief initially, but patients kept returning with pain recurrences. I realized that there is a missing piece in the chronic pain puzzle. I started looking for answers other than neural interventions. I was very fortunate to meet Chan Gunn, a pioneer of myofascial pain syndromes, and what he calls as IMS, intramuscular stimulation, is the name he gives to dry needling. I was highly skeptical about this clumsy looking, low tech intervention. See, I came in as a regional anesthesia expert, and to see this kind of pumping of needles into patients was repugnant to me. But I tried it as an add-on anyway to nerve blocks. And then I was astonished by the uniformly positive outcomes. People who had returned with pains were doing better. So in an attempt to understand muscles better, I returned to cadaver lab. I thought I can learn muscle anatomy in about 15 days. And to my dismay, I found I knew nothing at all. My undergraduate training had not prepared me for the vastness of muscle anatomy. It took me 6 months. However, those 6 months were worth their weight in gold, in that it produced a paradigm difference in the conceptual understanding of pain itself. Muscle is nature's choice for pain expression, never mind what the doctors say. And my 20 years in peds had shown me that the understanding of medicine in books keeps changing, often repeatedly, as new perspectives come in. So it was time probably for the perspective of muscle as a major pain generator in all chronic pains. It was long overdue probably. Anyway, what is dry needling? It's introduction of 32 gauge acupuncture needles into trigger points. However, it has nothing to do with acupuncture. Only the tool used is the same. Needles work by needle effect described by Carol Lewitt of instant analgesia and muscle relaxation, independent of any injections. I added ultrasound visualization to improve the accuracy of this procedure. Ultrasound safeguards peritoneum, pleura, vessels, and you can dance around nerves like this. And it also shows structural disruption in conditions like CRPS. This slide is showing you the normal heterogeneity which should be seen in a muscle, but the CRPS arm of the same patient, this is the normal hand, and this is the forearm muscles. You can see that this is a hyper-echogenic lump of muscle. We don't even know, it looks more like fibrous tissue than muscle. And this was something which I saw commonly in many, many patients. I reported this in 18 patients in 2013. More interesting about ultrasound is that it provides hitherto unknown insights into the nature of chronic pain. When you have pain of VRS 2 to 4, the muscles are quiet when you go in, but when you put a needle, there is this local twitch reflex which can be observed routinely. But when you do the same procedure in a patient with 5 to 6, you will see that the muscles go into a disco-like activity, continuous activity, instead of a discrete twitch seen here. And then you come to pains of VRS more than 8. You can see a lot of activity like this in resting muscle. These have not been needled at all. So ultrasonographic analysis of the USGDN, that is ultrasound-guided dry needling effects, allowed me to develop new concepts like neuromyopathy and viscerosomatic convergence. This is over the last 20 years. So if you look at the motor neuropathy consequences, this is the neuromuscular junction. Normal human miniature end potentials are very few. They are about 6 per second. Whereas in neuropathy, the irritable muscle fires continuously at the NMJ, causing about 110 per second MEPPs. Simmons called this as end plate noise in his integrated hypothesis. And this causes the actin and myosin to get stuck at the Z lines to form myofascial trigger points. These are contractures where there is local energy crisis, acidosis, etc. And Jay Shah et al., in a series of very elegant experiments, they showed they used a 30 gauge, very fine needle like this, as thin as an acupuncture needle, and with a peristaltic pump, they aspirated the milieu of MTRP, and they subjected this to capillary electrophoresis and electrochromatography and found an abundance of inflammatory mediators. So it is these inflammatory mediators in the muscles which cause sensitization of the peripheral nerves, nociception, and sympathetic recruitment. So when we do nerve blocks, what we are doing when we give them medications of somatosensory system nerve blocks, radio frequency procedures, spinal cord stimulators, etc., we are hitting pain at this level. We are leaving the primary pain generator, the muscle, alone. We are not doing anything to that. That is the reason why all these things have temporary actions. They are effective, no doubt, but the actions are all temporary, partial. Autonomic blocks go even further away, and that's why our beautiful stellate ganglion blocks, lumbar plexus blocks, etc., they have temporary actions in chronic pains. So coming to the abdominal pains, diagnosis and treatment of abdominal pain is difficult because the understanding itself is incomplete. This is Ford et al. GI microbiota, I was very happy when Dr. Igarashi spoke about the GI gut-brain axis, etc., which has a very major role to play in the whole metabolism of the patient. I will not elaborate this here. So we have recurrent abdominal pains in children, which is defined as at least 3 episodes over 3 months, affecting the activities of daily life. But organic cause is found only in 5 to 10% of children, meeting specific workup criteria. These are the workup criteria with fever, vomiting, blood in stool, forming the 3 alarm symptoms, and all the rest are here. In this, ultrasound seems to be a useful investigation in that it identifies abnormality in 10% of patients without these criteria. So functional abdominal pain is a clinical diagnosis in children who do not meet the workup criteria. The management focuses on improving the quality of life, reducing the patient and child concerns, reducing pain-associated disability rather than a complete resolution of pain. And then there are psychological therapies seem to be better than pharmacological treatments, though I have found antacids and H2 inhibitors like ranitidine to be useful in these patients. Now let us come to more serious pains and a better understanding of where does the pain travel in abdominal pains. This shows the nerves in the T5 to T11, which supply the gut and the back muscles. The dorsal ramus supplies the back muscles. The ventral ramus supplies the abdominal muscles. Then you have the celiac plexus, which provides about only 10% of input into the dorsal root ganglion, and through the greater, lesser, and least splanchnic nerves. And somatic nerves form about 90% input to this DRG. So 10% comes from the viscera, but 90% comes from the muscles. So there is a mismatch of the input into the DRG, which makes it the muscle pain to be perceived as visceral pain and vice versa, because these visceral nociceptor impulses travel through autonomic ganglia, but they do not synapse there. The first order neuron is the DRG, which also receives the somatic input. So this DRG in the thoracic region, T5 to T11 or 12, it receives visceral, somatic, and communicates with the autonomic neurons. It's a mishmash of all kinds of receptive data. The current therapies treat mild to moderate pains with medications and diet, moderate pains with opioid, non-opioid, analgesics, antispasmodics, and neuromodulators. Severe pains with organic pathology are addressed by nerve blocks, neurolysis, and radiofrequency procedures. However, the data in adults is abundant, but the data in children is quite meager. Celiac plexus block is limited to 3 case reports and a case series of only 3 patients. And celiac block was used a little late in the disease trajectory. And it may contribute, with this meager data, they conclude that it may contribute to reducing the pain, but not in really eliminating the pain. And then also in reducing the IV morphine equivalents. So my experience started in 2003 to 5, when I saw patients with abdominal tuberculosis with severe abdominal pains and chronic pancreatitis in teenagers. They all showed good response to neuromodulators. So I knew that these are neuropathic pains, which I later understood to be neuromyopathic. They had variable response to celiac plexus block, only about 51% response, whether it was fluoro-guided, US guided, or endoscopy guided. And this was about the world literature also, same kind of figures come in this. So again, I looked for other pain generators, and early pain literature, especially by Bonica in 1950s, pointed to viscerosomatic convergence. So the same diagram again, and there is a predominance of somatic input into the DRG in the back, so that the referral of visceral pain to body wall muscles, resulting in a regional myofascial pain syndrome, is partially because of all these mechanisms, afferent communications, orthodromic, anthrodromic, antidromic impulses, etc. But the fact remains that visceral pains seem to be felt in the back muscles and the abdominal muscles. And when we address these muscles, the oblique muscles, the rectus muscles, and importantly, the back muscles, these pains just go away almost. So we are not looking at reduction of pain, but significant reduction of pain. And in some patients, many patients, elimination of pain. So this, connecting the dots, visceral pain leads to viscerosomatic convergence and neuromyopathy with spasm of body wall musculature, which once initiated becomes independent of the visceral pain. The viscera may be normal after that bout of pancreatitis, but the pains continue to be labeled as chronic pancreatitis. This is exquisitely responsive to ultrasound-guided dry needling of the abdominal and the back muscles, and also to Botox injections. I'm sorry this child's face is being seen here. This is a boy who came to me. He was, I think, at this time about 9 years old. He came with very severe back pain and front abdominal pain. He required Duragesic patch and daily diclofenac injections. And in spite of all that, he was in misery. So I did a celiac plexus block in him with steroid. I don't like to do neurolysis in younger children because they have a long innings to go in life. So I just did a steroid injection, which produced about 40% reduction of pain, but he still required Duragesic and diclofenac. And then I did ultrasound-guided dry needling of abdominal and back muscles, which allowed him to go off Duragesic. But this child is a prima donna. He is the beloved grandson in a joint family, and everybody would hover over him whenever he got a pain attack. So he would throw tantrums, go to the family physicians, and demand for a diclofenac injection, which he was getting. So then I said, let me eliminate the pain in this guy. So I put in an epidural catheter, continuous epidural analgesia for about 20 days, which took his pain down to 0. And thereafter, he maintained normalcy. I haven't seen him thereafter, though I kept checking. He's saying Shunya Zala, means what? He had 8 to 10 pain to start with, and now it is 0. And these were the needles in the obliques and the back muscles. This is another child who, 11-year-old with 2 years of chronic pancreatitis and post-ERCP. She came with BRS of 8 in the back and abdomen. She had to come in a wheelchair and she had to be carried onto the bed. But one session of dry needling, and you see this girl here.
Very good.
Sometimes these results can be amazing. This child was one such. I have other boys, teenagers who have shown equally dramatic results and little slower results, but they all get results. This is another girl, teenager with chronic lower abdominal pain 1 year after ovarian torsion surgery, and she had also had lap appendicectomy. And currently she presented with 6 to 8 by 10 VRS, intermittently going to 10 on 10, aggravated by sitting for more than 15 minutes, standing, walking, turning sides in bed was all painful. Disturbed sleep, dysmenorrhea, and endoscopy showed H. pylori partial relief with the pain medication, for the medications of H. pylori. Psychiatric consult, she was not compliant with it. She discontinued the medications. The hidden triggers here, there are always hidden triggers in chronic pains. This child was a first ranker syndrome, severely anxious, desperate about her inability to sit and study, worried about the future. She's aiming for competitive exams, which are highly, highly competitive. So she had already received, by the time she came to me, NSAIDs, antispasmodics, muscle relaxants, pregabalin. She had received ilioinguinal, iliohypogastric nerve blocks. Somebody had done pulsed radiofrequency as well, and ultrasound-guided nerve hydrodissection, acupuncture, short. So all these had been done, but vitamin levels had not been assessed. I found that she had an abysmal 3.95 of vitamin D3, which we corrected. She was asthenic build. She was about 5'6", severe tenderness over the rectus abdominis and the oblique muscles. So diagnosis was post-surgical neuropathy with viscerosomatic convergence. And this is an adult study where they say that they just don't go to one segment, but the nociceptive afferents spread up and down the spinal cord and the whole of the nervous system. So in this girl, I did ultrasound-guided Botox because her exam was supposed to be in the next 2 months. So we did ultrasound-guided Botox into the abdominal muscles, into the back muscles. This took the rest pain to 0/10, occasional pains of 2 to 3. When she had got dysmenorrhea, the function improved over the next month. And she has given her exam just in the last week. She has been able to perform. I do not know what she will score, but she has given her exams. So the vagaries of viscerosomatic convergence are, if this is a normal looking muscle, this is a muscle with myofascial trigger points, with taut bands which shorten the muscle. And when we give something like Botox, which reduces the excessive acetylcholine at the NMJ with muscle relaxation, the myofascial triggers do not disappear, but they are still there, but they are reduced. That's why we get some amount of relief, but not all the relief. But the moment we come and do ultrasound guided dry needling, we take out all the remaining myofascial triggers. The Botox, when given, there is always a recurrence of all problems at 6 months post-Botox because there are residual MTRPs which make for further compromised muscle action and worsening of pain. Whereas when we do ultrasound-guided dry needling, we eliminate all these remaining muscles to restore normalcy to the muscle. And that's why we land up with a better situation, pain elimination, and very little recurrence of pains. Those interested in the muscle dominance in chronic pain and ultrasound guided dry needling, Botox, etc., this is my book, Chronic Pain Out of Box Treatments That Cure. And it's on Amazon. Thank you very much. I hope I have finished in time. I'm not sure.
Thank you so much, madam, for that lecture. It was so amazing to listen to you. There's so much that we can learn from you. And it's really good to have you back in our pediatric anesthesia community and in pediatric pain now.
Happy
So
to
I
be.
think, yeah, thank you so much, madam. I would now invite our audience so that you all can put in your questions in the Q&A box, and we can address each question. Madam, can you stop sharing?
Yeah, I've stopped.
Thank you. So I think what all of us agree on from all of our speakers is the multidisciplinary approach that we now follow for pediatric pain. And most of us are doing it. Our speakers have also shown us that, physiotherapy, counseling, and more of us are moving towards alternative medicines, the herbal remedies, and the child life therapy. And as Dr. Lakshmi Madam has also spoken about, that muscles are actually nature's way of expressing pain. Also school inclusion, which helps these children so much, coming into the mainstream and helping the other kids, helping them and learning from them, and that is also a part of the treatment now. So with this background, I have a question for Dr. Richard Kim. So I would like to ask you that in your case, which you had discussed, so you spoke about acetabular dysplasia. Is it the same as what orthopedicians refer to as femoroacetabular impingement, where due to trauma or some sports injury, the ligament is or the capsule gets torn, and then the femur keeps impinging during the internal rotation. And then that's when you get the lower back pain and the glutes pain, which radiates to the front of the thigh. Is it the same thing?
I had to switch my microphone, but can you still hear me?
Yes, yes.
Okay, perfect. Great question. Acetabular dysplasia and FAI are different beasts. One is instability, the other is impingement. Dysplasia is basically the primary problem is that the socket is too shallow, but FAI, on the other hand, is bony conflict, and that's causing some sort of pinching of some sort of entity in that area. So physical therapy and dry needling can help with symptoms and prep the muscles, but it won't fix the underlying problems. So PAO is definitive for dysplasia, and for FA, some sort of arthroscopic repair is often employed. Yeah.
Thank you so much. So you're saying eventually they have to go in for an osteotomy. That would be the preferred.
Not all dysplasia patients
Okay.
require a PAO. If it's mild and there's significant activity modification, any surgery can, of course, be avoided. But for
Probably
those that
with
are
dry
active enough,
needling.
yeah.
Right. Physiotherapy and dry needling, I think, is the answer to most of our questions now.
May I ask a question to Dr. Ayuko, please? So,
Sure.
okay, I am so fascinated about physical therapy and the inclusion of a pediatric child life specialist. I think that's something that we don't really have here in Indonesia. So if you can share your experience, what kind of physical activities or non-pharmacological approaches do your center use for children?
Well, I find that many children with pain, not especially headache, but abdominal pain, just withdraw from all kind of activity. And as a result, they just stay in their bed for all day, sometimes weeks. So sometimes children just confuse their pain, for example, abdominal pain to muscle pain. So the most important thing is to increase their physical activities. And the child life specialist or the nurses or whoever ask them out of the bed, out of their hospital rooms, and do something instead of looking into, for example, some screen content. Because watching the screen content, they keep the straight position. They didn't move the muscle, and that makes any kind of pain worse. So I think the most important point of treating any chronic pain in children is increase the level of activity. So like my case, introducing WeFit program is okay because it's activate the children's muscle and their activity level. So maybe my point is that increase the level of activity and increase the level of involvement with other children or other adults. Then children start to move around and they realize their pain is subsided. Can I answer my question?
Yeah, so I was thinking if you are in pain and you're staying alone in your room at the dark,
Yes.
watching the wall isn't going to help anyone. And I think the first beginning of the movement, when you try to get them out from the bed, I can actually hear my own children saying, "No, mom, I don't want to go outside. I don't want to do it." But it's maybe, your program using the WeFit. It's like something that they can, engage, like understand that it's not a task, but it's more like fun, something that they can do.
And often I ask children to open the window and open the curtain and take the sunshine in, which makes their sleeping rhythm better.
So just anything to change the mood, to change the situation will probably help. So thank you so
The
much.
pain is closely related to their anxiety or depression or their mood. So changing their mood is quite important.
It feels like you are advising me at work. So I have to go outside and maybe look at the sun sometimes.
Yes.
So I think this is an important message, not only for children, but for, I think, everyone who's listening. Thank you so much for the insight, Dr. Ayuko.
Thank you. Thank you for the great question.
Yeah, I do agree that for everyone that we can see that pharmacological and non-pharmacological is actually the mainstay of pediatric pain management. So I have actually a few questions from the attendees. First, I want to ask, I dedicate the question to Dr. Ayuko. And there's a question on what is the dose of Campo that you use when you give it to children with a headache?
Well, it depends on children's weight. But in case of children, maybe 1/3 of the dose we prescribe for adult is enough. And most of the time it's in a package. So in case of adult, we give 3 packages a day. So depending on the patient weight, maybe we prescribe 2 packages or just 1 package a day.
And do you prefer to give Campo rather than triptan to patients that already have resistance to ibuprofen and paracetamol? What's your preference?
I prefer to prescribe prescription of Campo because I have some experience with it. And the good things about Campo is that it doesn't work fast. So I always tell the patient or the parent that you don't see the effect of this drug until maybe 3 weeks later or 2 weeks later. And during that time, they can try something, increase their level of activity or do some exercise. And at the end of 3 weeks, they start to say that maybe I can see some result.
Right. Okay.
So it's not a clear cut. And that is the most point, the best point about Campo, I think.
All right. Thank you very much, Dr. Ayuko, for your answer. And for Dr. Kim, we have a question for you too. There's a question from Dr. Swing. The question is, how was the lumbar plexus catheter inserted before the hip surgery? Was it done under general anesthesia? And what is the rationale to putting the catheter in before the surgery? Does it work as a preemptive analgesia?
Sorry, I was typing out the response in case we couldn't get to all the questions, but briefly, we have dedicated block bays in the pre-op area at our hospital, so they're fully monitored, they're in lateral decubitus positioning, sedation is provided with a combo of like Versed and fentanyl, some music in the background. We don't do our blocks, especially in the teenage population under general anesthetic. We just do them all pre-operatively. For us, it's not a matter of belief. We know the preemptive analgesia works because of the data we've seen. And the question of rationale putting the catheter before the surgery, patients are in less pain. They're able to position themselves better. And in the United States, blocks, and maybe this is a global phenomenon, but we routinely have to fight tooth and nail with the surgeons in order to negotiate for optimal pain management for our patients. And any procedure that will decrease operator theater time is a procedure that surgeons will look favorably upon. So we took the blocks out of the OR, placed them in pre-op bays, and because of where the catheter is placed through the back, it's difficult for patients after the procedure for them to turn laterally. That's all.
Thank you very much, Dr. Kim. There's another question. Do you have any experience with quadratus lumborum block with catheter instead of lumbar plexus block?
Yeah, great question. So we do have experience with QL blocks, but QLs used to be ranked classified type 1 through 3. Type 3 is probably the closest to essentially an erector spinae plane catheter. And while we have had experience, we quickly moved away from them and went back to lumbar plex catheters because something that Dr. Vas mentioned, I feel is worth reemphasizing because not only are muscles potential generators of viscerosomatic pain, but more and more the regional anesthesia community is coming to the realization that we know nothing about fascia. We know nothing about connective fascia, and that fascia is different from one part of the body to the other, and that they too can be sources and primary generators of pain. And in the lumbar area, the connective tissues and the fascia that hold the erector spinae muscle complex in relation to the quadratus lumborum, they can be multi-lamellated. So just because you have tight retrosection in one plane that looks like the erector spinae plane doesn't mean you're actually in the muscle plane. You could just be laminating into the muscle complex. You could just happen to unfortunately open up a plane that carries none of the nerves that is relevant for the surgery. So ultrasound visualization can easily lead to false positives. So we moved away from that and went straight back to lumbar plexus blocks for the time being. There are a couple papers that have been published in the most recent edition of RAPM that discuss this with a couple interesting studies. Happy to share those resources.
Yeah, I do agree with Dr. Kim because cadaveric studies on ASP are yet to be proven, the spread where it actually goes. That's correct. And that I think that is a hot topic of research currently. There is another question to Dr. Lakshmi Vas, madam. What is the local anesthetic used in the child who had a continuous thoracic epidural for 20 days?
It was bupivacaine 0.125%. And he could walk, stand, etc., but he had only analgesia.
Thank you.
Yeah.
Somebody also wanted to know if the herbal medicine is available in the market worldwide. Dr. Ayuko, if you can give us some insight onto that.
Excuse me, would you please repeat the question?
Someone in the audience wanted to know if Campo is available worldwide, if it is freely available for us to purchase.
Well, I am not quite sure. I'm sorry that I cannot give you a correct answer, but the pharmaceutical company named Tumula is now open their website in English. So probably if you have the audience or if you have a question, please ask to the pharmaceutical company. It is called Tumula. And also, there are many overseas tourists here in Japan who buy Campo drugs in a drugstore because they have over-the-counter drug and they are exactly the same that we prescribed in medical institutions. So maybe you can order it online too. Sorry.
Yeah. On Amazon, yeah. We can try that. Maybe available on Amazon now. Also, a question for Dr. Lakshmi, madam. Madam, where can we, those of us who are interested in learning USG guided dry needling, so where can we learn it? Because there are very few people who are actually, doing it and practicing it. For those in the audience who are interested in learning it.
Yes. See, dry needling is taken to be the domain of physiotherapists, and very, very few doctors are aware of dry needling, nor are they, it sounds like something, paramedical, it's like acupuncture, or I do not know what are all the myths which are floating around about dry needling. But the ultrasound guided dry needling makes it into a very accurate science with mathematical precision, targeting of pain. I'm not talking about targeting of muscles, but targeting of pain. Now, I am the person who has developed it in its entirety. So I will have to hold workshops on it, which I do. I usually do about 2 or 3 workshops every year. And if there are enough pediatric anesthetists interested in it, I will definitely organize one for pediatrics only, not for the pains of, adult population. Of course, back pain, abdominal pain, headaches, etc. They all come in children as well. So I can organize a workshop as well for that, and I'll be very happy because the kind of results that are available is something else. And as you know, Raylene, we are doing a pilot project in cerebral palsy. Again, the results are miraculous almost.
Astounding.
So,
Yes,
yeah,
Dr. Lakshmi, I'm
will
the
be
first
very-
one interested to join your workshop, please.
Yes.
All of us are.
I'm the first
my
one to
favorite
participate.
group. Please
We
come
all
in.
want to collaborate. Yeah.
Yeah.
And Dr.
We
Lakshmi,
have
there's
produced
there's a question for you from the attendees. For abdominal pain, how do we determine which muscle is the best to do the dry needling? She says she have encountered many patients with abdominal pain, especially the post-op and mainly at the lower abdomen. So she wants to know which muscle is the best to do the dry needling.
See, if I were to give you a cookbook recipe, look at the pain diagram. The muscles which are underlying the pain diagram will be the main culprits. But all the no muscle works in isolation. They're all connected via facial layers to each other. And then there are agonists, antagonists, facilitators. Everything is interconnected. There is nothing in the body which is isolated. Everything is like this. So address the muscle under the pain diagram first, and then go for the other muscles of the abdominal oval. And also, see, one more thing I wanted to mention was that all these children's, this thing is done in teenagers. If you just do EMLA and paracetamol before or ibuprofen before the needling, they accept it well. In younger children, you might have to go for something like ketamine, sedation, or, whatever else, Dexmed maybe. But the older children accept it quite well. And after the first session, the relief is usually so significant that they are happy to come back and do it again.
Thank you.
May I answer another question which is there about how
Yes.
many sessions of
Yes,
Botox?
yes. Please do.
Yeah.
Go ahead. Please
Because
go.
that's important. Because usually Botox, I go very low on the Botox dose. I do not follow anyway, there are no recommendations for abdominal muscles. There are recommendations for headache, for the neck muscles and things like that. But there are no doses recommended for abdominal muscles, back muscles, etc. These are doses I have developed. And usually they are micro doses, because I'm not looking to produce weakness in the muscle. I'm only trying to reduce the pain by reducing the number of myofascial triggers. So I usually give one session of Botox, and then I do not do anything for the next 3 weeks vis-a-vis Botox. I may do ultrasound guided dry needling. If that itself is sufficient, I don't do any further Botox. But if the pain is still, pain always goes down. That's not a problem at all. It always goes down. Whether it has gone down by 50%, whether it has gone down by 30%, whatever it is, then if it is 30%, I may go and repeat after 3 weeks, because Botox takes 3 weeks to establish itself fully. Only then I will go for a repeat Botox in children.
Thank you.
Thank you very much, Dr. Lakshmi. I do have a question. How do we clinically differentiate somatic abdominal wall pain with visceral pain? Do you have any idea, or it can't be differentiated at all?
Yeah. See, when you have somatic abdominal pain because of a wrench or, sprain or some such thing, the history will be very different. They'll give you that history. Whereas if they have come with an repeated history of abdominal pain, especially these recurrent abdominal pain patients and all, then you have to look at the visceral pains, etc. But whatever the pain might be, if we do needling of the abdominal wall, it disappears any which way.
Okay.
I did this, by the way, even in my granddaughter, who of 11 years, who had repeated abdominal pains. So, of course, I had to bribe her a lot with many things, but then I did it. And after that, that pain is gone now. So we can, it's difficult to differentiate, but it's mainly because of the history, examination, etc. And one more thing I want to emphasize is please look at vitamin levels. Very, very important. vitamin D levels, vitamin B12 levels in patients.
I think, madam, also with experience, the kind of experience that you have over a period of time, after looking at the muscles itself, you know that this is, this is where the muscle that you have to target, just the look of
Yeah, but then always better to stick to the, elimination process of knowing
right,
whether there is any visceral. The history will usually eliminate
right.
things.
Okay, thank you for the great conversation today. And this is our cue. Thank you so much to all the speaker, to Dr. Ayuko, Dr. Lakshmi, and Dr. Richard Kim for your time and also your expertise. And also to all the moderators for spending a great Sunday of pains in the body, back, head, and abdomen, so that maybe we can take home something from this. And principally is that every pain, especially chronic pain, needs to be addressed not only pharmacologically. I think this entire session and all the speakers believe that multimodal approach is very, very important in chronic pain. And there are other drugs out there and other methods stronger than opioids in some settings, and those approaches must be approached by all that is interested in pain. And once again, thank you so much for all the audience. And the certificate will be sent to you after you finish the post-webinar survey, and it will be emailed tomorrow, which is February 16th at 5 p.m. Singapore time. And please ensure that you have your full name and email uploaded there. Don't forget to follow us on our website, our Instagram, our YouTube, and also on our Facebook. The recorded session will be available. So please do visit, like, and follow us. And ASPA tries to empower everyone through education. We are a nonprofit organization, and ASPA's mission is to foster the highest standard of pediatric care in Asia. So please do scan to donate, and we believe that your donation will help us to improve pediatric anesthesia services in Asia. And our next session will be a joint venture between ASPA and the European Society of Regional Anesthetists. We've had a regional anesthesia day I think it was last month on the end of the month. There was a lot of session going on, and this is one of them where science meets sensitivity in pediatric analgesia. It will be about regional anesthesia strategy on the pediatric patient, and we have all of our expert that's going to speak. So please do register. You can scan the QR on the left. And of course, we do welcome and invite you all to our ASPA Congress, which will be ASPACon. Block your dates. It will be on September 10th to 12th, 2026 at the Christian Medical College at Vellore, India. That will be organized by the Department of Anesthesiology of the Christian Medical College, Vellore. You may scan the information at the right bottom and also go to our website for more information. We are waiting for you all at Vellore. I hope I can see you there too. And by that, I think we are done and we're closing this session for today. Thank you so much for everyone. And I hope that this session can inspire everyone. And just like what Dr. Lasmi have said, maybe there is some anesthetist on the floor that wanted to do the bungee jump to go to chronic pain, and she would likely guide us. And of course, it is natural for the anesthetist to evolve to pain and to palliative care, because that is essentially who we are, about our love for children. It goes out of the operating room. And I think a lot of people would not understand why an anesthetist would go, but I think would go to that field. But I think everybody on this room kind of understand that the loves extend, beyond the operating room, and it goes beyond. So thank you so much for all your love, and thank you so much for everything that you do for children worldwide. And thank you so much for the audience and for this opportunity with ASMA. With this, I'm saying goodbye. Thank you. Have a nice day. Have a nice weekend. Goodbye. And happy Chinese New Year to everyone that's celebrating.